All right. There's a presentation up there, Chantry.
Yes, it is.
All right, cool. Okay, we'll get started here. My name is Jason Oreskovich. I am one of the family docs at the WVU Department of Family Medicine. Here to talk to you today about some clinical guidelines in the treatment of acute migraines. It's a fairly focused talk, and I was handed this topic, so we'll make the best of it. It's not going to be too long, so you might get some time back in your lunch today. Let's see. Am I going to advance? There we go. Okay. I swear it worked when we tried it out. Um, Disclosures, I have no financial relationships with any product that I mentioned in this talk today. I wish someone was paying me buttloads of money, but that's just not the case. Our objectives today, we're going to talk about what is an acute episodic migraine headache, understand the impacts that migraines have on our patients, and we're going to look at some medication options. And of course, at the end, we will break out what the official recommendations are from this clinical guideline committee from the AFP. So we're here to talk about migraine headaches today. Now, this isn't an actual picture of our mountaineer. However, he probably was seen doing this off camera given the football season that we had this year. Where did this talk come from? Dr. Unger, when she assigned this to me, handed me this article and said, here, you're going to do an echo talk on this in January. And I was like, well, okay. So this is the article. It's a clinical guideline article from the American College of Physicians on their recommendations for treatments of acute episodic migraine in the outpatient setting. What it doesn't cover is emergency department visits for status migrainosus, and it does not cover treatments for chronic migraine headaches. And we'll kind of get into the differences of that as we move along here. These guidelines, their application applies to the non-pregnant and non-lactating adults with acute episodic migraines in the outpatient setting. Definitions: an acute episodic migraine, by definition, lasts more than half the days of a month. Chronic migraines are 15 or more headache days per month. And of course, status migrainosus is one that lasts longer than 72 hours. Acute episodic migraines are known to be recurring migraine attacks happening less than half the days of each month. They have specific intense symptoms that usually require fast-acting treatments to manage each episode. And here you can see some of the characteristics of it. And even though my title was had aura in it, auras are actually optional for folks with acute episodic migraines. The impact this has, migraines are the second leading cause of global disability in all adults, and that is measured in years lived with disability. Happens to be the top cause in females, age 15 to 49. And in the US, 16% are actually affected by acute episodic migraines. And you can see the male-female breakdown there. And actually, the prevalence has been fairly consistent over the last 30 years. Some groups that are affected more heavily, the age range of 18 to 44, about 18% of those folks. Unemployed people actually have a little higher percentage of suffering from this condition, and also lower socioeconomic status also has a slightly higher percentage. Migraines will account for about 4 million emergency department visits every year and just over 4 million office visits every year. Now, they will cost the country about $78 billion every year, and that includes both medical expenses and lost work productivity. So the outcomes of interest that this paper looked at to come up with their recommendations, they looked at benefits and harms. The Clinical Guidelines Committee, and they also had a Clinical Guidelines Committee public panel. They rated clinical outcomes as critical, important, or less important for decision making. The items appraised for certainty of evidence included pain, pain freedom, and pain relief at 2 hours, sustained pain freedom and sustained pain freedom up to 48 hours, need for rescue medicine within 24 hours, and improvement in nausea, vomiting, and restored physical function at 2 hours. And they also, of course, looked at overall and serious adverse events, either from migraines or from the migraine treatments. They took into account patient values and preferences. So the public panel participated in the outcome rating exercise, and they provided preferences for interventions based on the systematic review's findings on the benefits and harms, and provided feedback on their draft guideline recommendations. And then, of course, they also looked at economic evidence. They considered economic evidence from cost effectiveness analyses and interventions, and they considered willingness to pay thresholds from the patient side. And then they also looked at annualized wholesale acquisition costs for each of the pharmacologic treatments that they were interested in. So the medication classes that they considered with these guidelines, of course, just plain old Tylenol was one of them, as well as our anti-inflammatories. And there's a list of anti-inflammatories that were considered there. And then they also considered, of course, the triptans, which are like kind of a mainstay rescue medication for migraine treatments. And then some of the newer agents, such as the CGRP antagonists and the DTANs, and then some older ones, such as the ergoalkaloids. And of course, they also looked at combinations of these treatments as well. So since they considered cost, and we should too, when we're telling patients what they should do when they get a migraine headache, we'll look at some of the costs. Now, these were taken from GoodRx for the most part. And these also, if you're paying cash. So start with Tylenol. Tylenol, relatively cheap. So you can get like 500 of them for $8. Only comes out to less than 2 cents a tablet. So, taking 2 extra strength Tylenol, you're looking at a whopping total of 3 cents for that treatment. And you'll see as we move on in these how that vastly will go up in price. On the anti-inflammatory side of things, looking at ibuprofen generic, it's a little more expensive, but not much. 2 cents a tablet, take 2 of those, you got 4 cents in a dose. Naproxen, price goes up a little bit with the over-the-counter Aleve, up to about 6 cents a tablet. Celebrex, now that it's generic, has come down in price. It's a big jump in price, but still relatively cheap, coming in at 37 cents per dose on that one. And then they also looked at diclofenac potassium, which is a 50 milligram tablet. Now that's most of the time the diclofenac we prescribe for injuries is diclofenac sodium 75 milligrams, which is just a different salt. But here it comes in at a fairly reasonable price at around $0.25 a pill. Triptans. So triptans, of course, are the mainstay of rescue treatment, have been for years, since the 90s when they first came out. Costs have come down on these considerably, since most of them are generic now. So it makes these more affordable options for everybody. So I ranged these from the cheapest to the most expensive. Starting out with rizatriptan, goes by the brand name Maxalt. And again, generic version, not too bad. Coming in at just $1.50 a dose. Sumatriptan, which is the one that's been out the longest, Imitrex. Again, not too much more expensive. Naratriptan, which has become kind of a popular one here lately, goes by brand name Emerge, still fairly reasonable at 2.25. Elatriptan or Relpax at 265 a dose. Frovatriptan, which was a new one on me. I've never prescribed this one personally. It is just slightly more expensive. And then we have Zomatriptan or Zomig, and Almotriptan or Axert is our most expensive one, coming in at about $11 per dose. Now we start getting into the sticker shock. So these are the CGRP antagonists. That stands for calcitonin gene-related peptide antagonists. Doesn't mean much to me, but maybe if there's any biochemistry nerds out there, they know exactly what that does. Same thing, I arranged these from the cheapest to the most expensive. And here you can see Ubrelvy, which gets advertised a lot, still brand name. $1,673 for 16 of these, coming in at 105 per dose. Just goes up from here, folks. Nurtec. Nurtec also comes in an oral dissolvable tablet as well. And it is $1,040. Seems cheaper, but that's for only half as many. So the cost per dose is more expensive. The winner in this round is Zavegepant or Zavspret. Now this one is a nasal spray. So $1,150. Now that is for 6 sprays. So this is not something that you do a test spray on, because every time you go, that's $200. Now the class of DTANs, there's only one in this class. This particular class binds 5 HT1F receptors, and it inhibits trigeminal nerve firing. Lasmiditan, either the 50 or 100 milligram tablets, same price for each, coming in at about $90 per dose, and that's per tablet. Now you can go up to 200 milligrams with this, so you can, I guess, jump up to 180. Our ergo alkaloids, an older one. The others are mostly injectable, but this one here, dihydroergotamine, goes by the brand name Migraine. Some pharmaceutical company figured out how to monetize this one again. Not as bad as some of the others that we just looked over. Still about $35 per spray on this one. But through that entire paper, it all came down to something very simple. What's the bottom line on all of this? It is not very exciting. So I added some fireworks in to try and liven this up. So yeah, big wow. And we'll go through this and oh shoot, I'm sorry. I don't know how that one got in there. Okay, so the recommendation number 1 from the Clinical Guidelines Committee, they recommend that clinicians add a triptan to a nonsteroidal anti-inflammatory drug to treat moderate to severe acute episodic migraine headaches in outpatient settings for non-pregnant adults who do not respond adequately to just the NSAID alone. And that's the bulk of it, folks. An anti-inflammatory and a triptan. So if you remember right, those were a couple of our cheaper options out there. We do have some nice, shiny, brand new options that are much more expensive, but if you want the biggest bang for your buck, tell your patients to keep some ibuprofen or naproxen on hand. take that first, shoot a triptan along with it, and that has the strongest recommendation with moderate certainty evidence. Now, they did make a second recommendation also. Not much more exciting there. It's just add a triptan to acetaminophen for the same thing. And this is going to be mostly for those patients who an NSAID maybe is not a good option or maybe contraindicated, such as if they're taking a DOAC or something along those lines. However, it's a conditional recommendation. It has lower certainty evidence. So after reviewing everything, basically combination therapy of a triptan and an NSAID compared with triptan monotherapy resulted in a higher likelihood of sustained pain relief up to 48 hours after the initial treatment and lower likelihood of requiring a rescue medication at 24 hours. In addition, combination therapy of triptan and anti-inflammatory probably results in a higher likelihood of achieving pain relief at 2 hours and sustained pain freedom at 48 hours. The evidence, however, was inconclusive to inform recommendations for monotherapy with the CGRP antagonists, the dihydroergotamine or lasmiditan. So, unfortunately, the evidence doesn't weigh heavily in favor of our brand name stuff, which is how we should be looking to prescribe patients the cheapest thing so they can't afford it. And, folks, I know it was short, but that is what I had for you. Yeah, do we have any questions?